the whole matters World Anaesthesia Day. So according to the World Federation of Societies of Anesthesiologists, the number of cancer cases is set to increase from 19.3 million to 28.4 million by 2040. As the world marks Anesthesia Day today, we're taking a look at how anesthesia is paramount in basically providing the whole cancer care. So be it the whole general pain of it. And joining me for this particular conversation this particular morning, the bright minds for this, the very few, by the way, in this particular country, Dr. Ruth Mbadi and also Dr. Rachel Kimani-Njiri. Both of them are consultant anesthesiologists.
Yes. Yes.
I have pronounced that correct.
Very right. I was going to say that one, yes.
It's always quite a mouthful one. First of all, I'll start with the Dr. Mbadi. Why do we even have a day like today, World Anesthesia Day?
So the reason we have this, the World Anesthesia Day is to celebrate the work of anesthesia providers all over the world. And it's a practice that started many years ago. And particularly we have themes every year that we focus on. Last year it was medication safety. This year we're focusing on anesthesia and cancer care. Mm-hmm. Yes.
Right.
Yeah.
And now to you, Dr. Kimani, your experience working with cancer patients. I'll also get your experience. Mm-hmm. And I'm asking this because even the World Federation of Anesthesiologists, well, is really curious for anesthesiologists out there worldwide, what the experience is, telling them to share on social media. So I'm curious, what is your experience?
Okay, just to add on what my colleague has said, this day was started on 16th of October in 1846 by a man called William Morton, whereby there was the discovery of ether as a mode of providing anesthesia. So it was a breaking point on how anesthesia anesthesia provision would begin worldwide. And now, come to 1903, the World Federation Society of Anesthesiologists took the initiative to make sure that this day is commemorated globally by every anesthesiologist in the world, and they're able to appreciate what the anesthesia team and the anesthesia fraternity actually offers. So the main idea behind this day is to celebrate the leadership and the expertise, the clinical expertise that anesthesia fraternity offers and the relevance it has to the community and to all the patients globally.
All right. And okay, before we actually now cross to Dr. Mbadi, your experience working with cancer patients.
So for an anesthesiologist, when we come to working with cancer patients, we work through a wide spectrum of activities. So you're looking at activities whereby you'll offer the pain care, you'll offer the intraoperative management if the patient requires surgical intervention, and you'll also offer palliative care. So what happens when you're offering this care to the cancer patients, it's a holistic and a multidisciplinary approach. You're not only working alone, you have the oncologist with you, you probably have a physician with you, and all this approach is now in a multidisciplinary way that will enhance and offer good outcomes, because at the end of the day, we are interested in perfect and good patient outcomes.
Okay. You raise an interesting bit there, perfect. I'll get to that because, I mean, how perfect really is it? But then, matters being perfect, there might be errors there.
Yes, there's always...
How often in your line of duty does that?
I would say less than 1%. It's a very minimal, small margin of errors, because when you're looking at all this all this care that you're offering, you want to think it through. You want to ensure that there's patient safety. You also want to ensure that your patient is aware of what's happening. So there's also patient education. It's a patient-centered care. You also want to ensure that the rest of the team, the surgeon or the oncologist, we are all at par in whatever care or whatever interventions that you're offering to these patients. Out of all these patients that we are seeing in cancer who have been diagnosed with cancer, we have about maybe 80 to 90% who oftenly require surgical intervention. So by the time a patient is requiring an anesthetist to come on board, this is a patient you've been walking through from maybe day 0 or day 1, and you're following them through till the point whereby now you're taking them to be it theatre, or is it a matter of if they're in the palliative stage, you're thinking about how will you manage their pain, because most of the patients actually do complain about pain. Pain is a nightmare in a cancer patient. So that is where also we offer our expertise. Right. And to add on to that, some could also require critical care. They need ICUs, they probably need a HDU. So who mans the HDU in our countries? In our country, most of our critical care units and our high dependency units are most often manned by anesthesiologists. So that's also another role that we come into playing. Right.
And Doctor, but even as you also share your experience working with cancer patients, so who's the boss in the surgical room? Is it the anesthesiologist? Is it the surgeon? Who calls the shots here?
Before, that question would have had an answer, but now we focus on teamwork. Together we achieve more. So everyone plays a critical role in the, because our focus is a good outcome for the patient. So there's no the boss, but everyone, or who's the boss, but everyone plays a very critical role. Because without anesthesia provider, you cannot have surgery. If without surgery, I mean, the patient suffers. Yeah. One more thing I wanted to add, you asked about errors.
Yeah.
I wanted to add that anesthesia is one of the safest specialties, because, you know, one of the reasons why people join anesthesia is because of the way you get your outcome immediately. Like you give a patient medication and in 30 seconds they're asleep. So we have very minimal, little margin for error, and that's why most of our practice, we borrow from the aviation industry in simulation before we do things, so that we're able to make sure that we have a very narrow margin of error. So it's one of the safest specialties because we're very careful. In fact, most anesthesiologists have OCD.
Oh, okay.
Yes, there's a way we do things so that we have the same outcome each and every time.
Is it the fact that, and is it the reason that you take, is it about 6 years, or how many years to study anesthesia?
For physician anesthesiologists, because they're different cadres, we are physician anesthesiologists. After you finish your undergraduate degree in medicine, you take 4 years to train now for your Masters of Medicine in Anesthesia.
4 years?
Yes, and then after that, you can decide to specialize. And now people who've subspecialized, we have people who have cardiac anesthesiologists, we have neuroanesthesiologists, we have people who are just pain specialists. You know, pain is actually a whole subspecialty on its own. We have people who do regional anesthesia, we have people who do transplant anesthesia. I mean, it's wide.
Right.
Yes.
And even putting matters cancer just aside kidogo too, so how many, and for Dr. Kimani, how many are you, the anesthesiologists in Kenya? How many are you?
All right, for the physician anesthesiologists, we are 216, serving a population of, are we at 45 million now as a country? So we're already a small percentage of what is required by the WHO. The WHO requires 4 to 6 per 10,000 population anesthesiologists. We are at a figure of less than 1. So we're at a point whereby the country needs to improve and needs to increase the number of physician anesthesiologists that are getting out of the university. So platforms need to be created, and right now more training is added onto it.
Is it that the course is tough? Is it that people are not interested in studying this course?
The course is tough, for sure. It is quite tough, but maybe it's a matter of, is there much advocacy for this field? Is it well known? Is it something that's been advocated for? Because most people only think about anesthesiologists when they're thinking of going to theatre. But we have other roles. We're not just in theatre, we're in the critical care unit, we're in the pain clinics. So it's just a matter of advocacy. But to add on to that, we also have non-physician anesthetists. And these are the clinical officer who are usually trained through most of the colleges like KMTC, Kenya Medical Training College. We also have now a new cadre that has come in called the nurse anesthetists. That course is being offered in various colleges in the country. But these courses are usually less than 2 years training exposure. So it's a matter of less than 2 years. So we have these cadres that have come in to help serve the gap, or to help bridge that gap that is there for the physician anesthesiologists. But that doesn't mean to say that they're taking the role of the physician anesthesiologists. Mm-hmm. We as the physician anesthesiologists are entitled or should offer supervision to these cadres that are coming, these lower cadres that are coming should work together as a team.
Right. And you bring a very interesting bit, because I remember even last year in some of the papers and even a whole study, there was a whole wrangles between who should be giving, which particular, who should be administering what, the whole cadres. And Dr. Mbadi, just to also chime in on that, when you take a look at, for example, when you deep there in the rural setup, they won't probably have someone of your expertise, but then they probably have a nurse. The nurse may not have the whole knowledge of administering anesthesia. So how does this work?
So first thing I'd like to say is that intercadre wards are all over, they're everywhere. Mm-hmm. Even engineers and technicians have those intercadre wards.
It's quite a normal kind of.
But we have different cadres of anesthesia providers with a set and a very clear roles and things that they're able to do. And that depends on each particular cadre's skill set. But truth be told, 216 people can't serve the whole of Kenya. And for a very long time, it's actually clinical officer anesthetists who've been giving service delivery in Kenya in all the rural areas, even before the nurse anesthetist came. And so it's actually complementary, because there's a role we play, there's a role they play, and we also try to strengthen that particular system by training. So we have like Kenya Society of Anesthesiologists, that is the body that physician anesthesiologists fall under, tries to offer regulation. We actually developed a national anesthesia guidelines. We offer training. We've partnered with different counties to train clinical officer anesthetists, refresher training, just to make sure that the practice is standard and up to date. Yeah, so it's actually complementary, but we have different roles we play depending on the skill set that we have.
Right. Let's now focus on matters cancer. And so according to the World Federation of Anesthesiologists, basically talking about how resourcing of anesthesia and how it should really be done on a large scale. And just to get it right, many parts of the world are not receiving the care they need because of inadequate resourcing, quote unquote, according to the World Federation. So what should we be doing to do more resourcing?
All right. So for sure, resourcing is a challenge, and it's a huge challenge, not only in African setup, it's also in the global world. So what is required as a country is to think about what care or what level of equipment, what level of drugs are needed, how many ICU beds are required, how many theater spaces are required in a country, so that we can be able to serve these patients adequately. Because we can see that the number of patients is increasing. As the number of patients who have been diagnosed with cancer is increasing, we have also the needs increasing. We have these patients wanting to go to ICU, wanting surgical care, wanting pain care. So it's a matter of now thinking about what do we prioritize? And thinking about it, we can see now in the new health bill that they have brought in an aspect in the social insurance health bill. They have brought in the aspect of emergency and critical care. Mm-hmm. So these patients could also fall into that health bill, because you never know, they could have, they will need critical care, and they will need critical care management. So that at least we can see that as a country, we are trying to sort out that gap, and we're trying to bridge that gap in the insurance bill.
All right. And when you talk about resourcing, and you also mentioned even the kind of medicines, which now specific medicines should be used, and which kind of medicines have been given the a green light to be used in Kenya?
For anesthesia, we have a whole different range of medications, but we have two types of things. We have the general anesthesia. This is the medicine that will take you to sleep completely. And then now you have others for regional and for pain. So when you're thinking about what medication that you're going to use for these patients, most of them tend to go through general anesthesia. So you're looking at the medication that is required for this specific type of anesthesia technique that will be used on these patients. Right. So when it comes to prioritizing as a county, or even as a county boss, those are some of the things that they should think about. What kind of medication will be needed? Should we increase the quantities? How do we source for it? How do we plan for it?
Right. And even as we talk about, Dr. Mbadi, even as we talk about matters, according to even the Federation, talking about increasing 19.3 million to 28.4 by 2040. These are the cancer cases. She talks about even the kind of sourcing for this particular medication. So does cancer have, again, a whole specifications of this is the anesthesia to use for this particular cancer? For example, if it's breast, this is the kind of the anesthesia that you'll use? Is it bracketed like that?
Before I answer that question, I think the question also would be why are we focusing on cancer this year? It's because, during COVID, emergency surgeries were not being done.
All right.
And you realize that almost 80% of patients with cancer will need surgery. For example, the top 5 cancers in Kenya is colorectal cancer, breast cancer, cervical cancer, prostate cancer, esophageal cancers. All those need surgery at some point. And when we talk about anesthesia involvement in cancer, it's from diagnostics. Diagnostic is, for example, the mother I come from Home of Untold County, Uko Suba comes and they have a lump in their breast. I mean, how do you know whether it's cancerous or not? You need to go for surgery. They take it for diagnosis. Then after that, if it's cancer, you now start planning treatment, which at some point may involve mastectomy, removal of the breast. And so you find that, I've lost my train of thought. You find that, what did you ask me?
Okay, basically, the whole bit of the fact that this particular cancer cases might be rising.
Yes,
by 2040. So how do you know that?
Which anesthesia to use?
Yes, for which cancer?
So, the type of anesthesia depends on where you're performing surgery. Though currently, with advances, we can do regional. Regional means you give anesthesia to that particular region only, because we've ever done a mastectomy just with blocks. Blocks means you block the nerves that supply that particular area. Okay. Then it becomes insensate and surgery is able to go on. So it actually depends on the area of surgery. For example, if it's your hand, you can just do blocks. So
by region, you mean region of the body?
Yes, the region of the body that you want to operate on. Yes. But let's say it's stomach cancer. That one now you have to sleep completely so that they operate on your tummy. But generally with general anesthesia, which is sleeping completely, you can operate any part of the body. Yeah.
So even the fact that now cancer might be the head cancer, rather...
You have to sleep for head cancer. Yeah, so this is more the technical aspect of giving anesthesia, but it actually just depends on where you're operating. Yes.
All right.
And then also I want to go into the molecular discussions on this type of cancer, this type of anesthesia might cause recurrence. I think it's beyond the scope of this discussion.
Obviously steering away from the whole technical bit. Yes.
Yeah, I think I just want to add on to the reason why the global community is feeling that the cancer cases are going to increase. It's a matter of what are the trends that are changing globally. We have lifestyle changes. We have people with less activity. We have the obesity epidemic. We have more patients who are coming in who are obese. And these obese patients are certain cancers are associated with obesity. We have like colorectal and breast cancer, which are associated with obesity. We also have the issue of genetic modification, the types of food that we're taking. We no longer know, or we no longer say that, there's an issue with the processed foods. Well, I cannot be quoted anywhere because I do not have enough facts to that, but processed foods could be attributed to the fact that they're causing a whole genetic modification, which could cause an increase in the cancer cases in the country or in the world.
And environmental pollution also.
Right.
On the rise, yeah.
For example, now maybe the patient is, do you say on the table or under the knife? So something like that.
On the table first.
On the table, before being under the knife.
Yeah.
All right. So Daktari, so this particular patient, maybe you haven't probably, it's one of those emergencies and you realize actually this patient needs a surgery at the moment. Or, maybe it was an accident. You don't really have enough medical history of this patient. So how do you determine that this particular medication might harm this patient later on? Probably they had a previous maybe infection or something like that, such that this particular anesthesia that you're going to maybe inject might affect this patient.
So as Buddy told you that anesthesia, we're like aviation. We are very careful with what we are doing. We always have checklists. We always have standard operating procedures. So even in an emergency situation, when you have that patient who's before you, there are things to look at. There are early warning signs or early recognition signs. You want to check the vitals. The vitals, basically, you're looking, how is the blood pressure of this patient? How is the respiratory rate? How is the saturation? What is the oxygen saturation of this patient? So all those parameters will give you an indication of how critical or how compromised, how hemodynamically compromised this patient is. So depending on what these vitals will tell you and your primary and your secondary survey of this patient, you will then decide this medication is safe and this one is not safe, because there are certain medications that we can give and can have an effect on our blood pressures, and there's something that we'll give that will help at least they'll improve the cardiovascular output. So we look at it in a very critical manner, and we always go in not on our own. If you're having a difficulty or if you feel that this patient will be a challenge for you, there's always room to consult, and there's always room to talk to your surgeon or whoever else is involved in that case.
All right. So basically, it's a matter of in seconds and all that before you actually come to a conclusion. We are going to be using this one.
Yeah, it's something that would take maybe 10 to 15 minutes after you've analyzed, because there's also the other aspect of what are the investigations that have been brought in for this patient, what has been done. So all that knowledge, you put it together, and then you decide, this patient, I'm going to do this. This is what will knock him out, and then this is what will bring him up.
Right. We are doing a short break, so you can hold that particular thought. Don't forget it. I love the fact that she says, knock him out. Anyway, we're taking a short break. When we come back, we would like to also focus on the whole advancements that have been in the whole field of anesthesia, among others, even a whole bit of, not only even in Kenya, but also Africa as a whole continent. What should we be doing also, even in the whole octo anesthesia? Stick around for that.
Did you know that Mount Kenya University is the most affordable university
care and the whole primary care and the general pain for this particular, for cancer actually, and the fact that this particular month is Cancer Awareness Month. And well, before the break, both consultant anesthesiologists were sharing the whole experiences when it comes to cancer patients. And I'm curious, by the way, since Dr. mentioned 1846, it's about 100 and something years ago, till now, in Kenya, Dr. Are there any advancements in this field?
Yes, they're there. I think the first one I'm very passionate about and I want to talk about is that you can deliver without pain. You don't have to have labor pain. Mm-hmm. Yes, so now, you just go, we give you an epidural, you're walking, you're saying your stories, and then when it comes time for delivery, we keep on monitoring you. Then you just deliver. There is no pain-free delivery is available. That's one of the advancements that is really big for me and for women generally. The other one also is nowadays you can come to hospital, get your surgery done, and you go home. Of course, that depends. There's a criteria that is followed for daycare surgeries. The other advancements that we have is also on pain control. Mm-hmm. And it really pains me that pain is still a big burden in the country because I think of the social, the way people see pain as a necessary burden, vumilie. You don't have to. pain can be taken care of. There are people who have learned about pain. In fact, as Kenya Society of Anesthesiologists, we've been training, like we go to counties to train people on essential pain management so that the healthcare providers in those centers are able to actually treat pain, just refer the very necessary ones. So nowadays, I mean, if you go and probably an example is if you have maybe pancreatic cancer, one of the worst pains, you can just go, they use imaging, they go inside there with a needle, they put some medicine and the pain goes away, especially for palliation. Yeah. So there are very many advancements that are, I don't know if Dr. Ari can remember some. Even advancements in, for example, as I was telling you, pediatric anesthesia. Yeah. Like in Kenya now we have subspecialties. Those specialties I was telling about are in Kenya actually. Okay. So that you find that a baby is attended to by an anesthesiologist who is who has studied on anesthesia for children.
So that means
children are not small adults, yeah.
That means even for kids and even for adults, they have different,
very different
kind of medication for anesthesia.
It's the same medication, but just how it's given, the dosage, or what is given at what point, and some that are not given. In fact, when you read medication, you read the insert, there are medication that you not give to children under 18 or even 12 years old. And even the physiology of children, their anatomy is very different from adults.
Right.
Yes.
Now, the elephant in the room here, even for cancer patients, Dr. Ari, now after addiction, is this on the table here? Because you'd find, and this even some years back, for example, in America, when Oxycontin was really brought up, and when she talks about pain medication, people shouldn't really be complaining. People shouldn't really be saying pain is a burden. So people out there realized, oh, okay, you can really profit on pain. And this particular field really lies there because can someone be addicted to any of this anesthesia? Is that a possibility?
Yes, it's a very huge possibility. Some of the medication that we use is the opioids. The opioids is in the class of the morphine, the fentanyls that we have in theater. Those drugs are usually highly addictive. So they're very, the rates of addiction from these drugs has gone up because if the patient has chronic pain, it gets to a point, even as doctors or an anesthesiologist, when we're managing this patient, we're not able to tell whether is it the real pain or is it a patient who's now becoming dependent, and from dependence they get into addiction.
So how do you balance that scale?
So it's a whole spectrum of activities that you have to do. We have a pain score, we have a pain scale whereby you have to try and see the level of pain. Is this patient having pain which is at 10, or is it a pain? Is this patient experiencing pain which is at 5? So we also have a scale that usually gives us a direction on how to manage this kind of patients. But at the back of our minds, we also need to know that the drugs that we're offering and that we're giving are very addictive, and we have to be very careful in how they're handled and how you give the patients.
Do you want, before you chime in this, do you want the patient, maybe before, that we might be, or rather we will be, administering this particular anesthesia? It is going to be addictive. Do you give that warning? And in a case where, again, that whole hypothetical of an emergency, there's a road accident somewhere, and again, as you're saying, you're very categorical in how you did the whole 15 minutes. You administered, underwent surgery. Now, after, do you again tell the patient this is the kind of anesthesia that we used on you?
For us anesthesiologists, we are patient advocates. We involve the patient from the beginning till the end. For every little thing that we're going to do, everything that we're going to give you, we'll give you the advantages, the disadvantages, we'll give you the risk factors that could, the adverse reactions that we could get from these drugs. So we always involve the patient in every step when we're managing a patient, and we let them know that this is going to happen, and this could happen, and should it happen, what to do. There's something we also do, we take lots of consent, because this is the era of litigation. So we have to take lots and lots of consent, and the patient has to be very aware of what is being done to them and what is being offered to them.
Right. And right, so you've definitely told them that this is maybe what we administered and all that. So first of all, Is there a hole in your experience? Does that happen a lot? The fact that maybe out here, there's a whole addiction of some of these opioids. And again, which particular medications, opioids rather, should be used and which ones should not be used?
I wouldn't say it happens a lot. The percentage, I'm not so aware of the percentage of the rate of addiction from these drugs. But the ones that are usually highly addictive is morphine, which is very highly addictive. You have fentanyl, and then you also have one that has come in called tramadol. Tramadol is also, it has morphine-like characteristics. So it's also one of the drugs that is now being abused outside. Patients will present with, like feigning symptoms of how they're in pain, but you come to realize this is, this is a seeking behavior. This is not pain. This is something that the patient is asking for. And you have even other drugs that we call the sedatives, which is like the midazolam, the domicam. Those ones are also very addictive because they will, if you're having problems with sleep, if you have sleep disorder or if you have stressful situations in life, people tend to use them because they'll put you to sleep, and at that point you feel like it's solving your problem. So some of those drugs are also abused,
right.
the sedatives.
But is ketamine supposed to also be on this list? And,
yes, I was shocked that people actually smoke, like they snort it.
Yeah. And the reason I'm asking this is because last year in the dailies they're quoting that, well, in some poorly resourced facilities, non-physicians are also allowed to use sedation drugs such as ketamine to facilitate essential surgeries. And again, the whole cadre wars and all that really brings up maybe one would suggest no, we use this one, other one would suggest no, this one should be used.
So I'll start by saying that all this medication you're talking about are very tightly regulated. But sometimes you can get what you want. I mean, there's a way they find themselves you can find those drugs in the streets.
In the market, yeah.
Yeah, in the market. But they're very tightly regulated. The Kenya Pharmacy and Poisons Board has regulations on who can access and who cannot access. The second thing I wanted to say is that before I mention the ketamine question that you've asked that's very key in this discussion, is that even as those addictions are there, but we also have ways in which we try to reduce the chances of a patient getting addicted, because addiction comes because of repeated exposure. But we have now what we call opioid sparing pain control mechanisms. So you reduce the opioids, and the other things you can use to control the pain, including regional anesthesia techniques. Then about ketamine, when you say that in poor resourced settings, I don't know if you're talking about essential ketamine, we put that story to sleep because the mortalities that were happening because of ketamine in untrained hands on unsuspecting people was so bad. It was high. So ketamine is a drug that is very useful and very important and keen in giving anesthesia. But when it falls in wrong hands, and when a patient goes to the hospital, they trust that whoever is attending to them knows what they're doing. Yeah.
Well, they have a lab coat.
Yeah, they know what they're doing.
Yeah.
But of course, as we had said before, we have training in anesthesia, different cadres. You have physician anesthesiologists, you have clinical officer anesthetists, you have nurse anesthetists. We don't have anyone else outside that cadre.
Yeah.
Yes. And those three know what to do in their training.
And all three cadres are in the society of...
Yes. Yeah. No. The physicians are the members. Then now, if a clinical officer or nurse would like to join, they join as associate members.
Interesting.
Yes.
Okay. Would you like to...
I'd like to add on now, for the rest of the cadres, each one of them has their own society as well, which offers them some professional support and some regulatory support. So they're not in the KSA, Kenya Society of Anesthesiologists, but they can be associate members.
Right. So, ladies, so next year, around March there, is the 18th World Congress of Anesthesiologists. I'm curious, your expectations on this, because, we're definitely talking a lot, and Dr. Kimani is quite vocal about this is what we need, this is what we need to do, this is what we need to do as a country. Hopefully you'll be attending this particular, Congress.
That's the plan.
Yes, that's the plan. We do plan to attend.
Oh, great. So now I want to hear from both of you, your expectations on this particular Congress, and because Kenya is going to be represented here. What kind of voices should be heard? I'll start with you, Dr.
You know, in this particular kind of Congress, the attendees are anesthesiologists from every part of the world. So you're having expertise that is coming from Africa, from Asia, from Europe, and then we come in together to exchange knowledge, to identify ways to move forward, to identify how some countries are doing their anesthesia, how they're offering their anesthesia, how some countries are doing their work. So it's a platform whereby we are able to network and we're able to build relationships. We're even able to build partnerships, and especially for us as the Kenya Society of Anesthesiologists, we usually run training programs, and some of these training programs, as she had mentioned, is the essential pain management. We have safe OBS, we have safe pediatric management courses. So these courses, we usually give them to the health cadres or even refresher courses to anesthesiologists to come and, you know, to refresh their knowledge. So through this Congress is where we hope to build significant partnerships, and partnerships that will help us in improving the healthcare and to improve the workforce capacity in this country.
All right. Dr. Mbadi,
I'd like to build on to something she has said about her training, that there are counties in this country that have really trained their workforce. And through partnerships with KSA and other organizations that I will not mention. So if your county has not been trained and you're watching this, please reach out, because it actually impacts the quality of care that your I wanted to say your members, but the population gets, and even access to that care.
So whose role is it to reach out, per se? Because
sometimes
probably you won't find a resident of, for example, Homa Bay reaching out to KSA and saying, we need this particular pain management kind of skills and all that. It might be rare. But then, is it the role of the doctors from the public hospitals there? Is it the role of the CECs of health? Is it the role of the governor? Whose role is it really?
Actually, the partnerships we've had, it's actually been the CEC Health reaching out, or someone in management of health in that particular county reaching out. Yeah, because members may, but now there's a process. Yeah. Right. The question was what we hope to benefit from WCA. Yeah. On top of what Dr. Kimani has said, we also, it's normally a time for KSA to also, we can have a booth. Actually, we're supposed to have a booth to also share on things that we do and just develop partnerships, as she has said. And one of the things that really we benefit from such is training opportunities for Kenyan anesthesiologists. You find that you get to network with people who are in different institutions, and you're able to go and train and bring that knowledge back home. All right. Yes.
So before we actually wrap it up, I want to pick your minds on a recent study. It is quite mouthful. So this particular study, and now the conclusion of it, just an extract of the conclusion says, the title is of this study is Post-Operative Outcomes Associated with Procedural Sedation Conducted with Physician and Non-Physician Anesthesia Providers. So the conclusion says, in Africa, the practice of procedural sedation by non-physicians compared to physicians may be associated with an increased risk of severe complications and death. It finally says the working environment in which non-physicians have to provide procedural sedation may also be a negative contributor to patient safety. I'll start with you, Dr. Kimani, on this particular extract. What are your thoughts on this particular conclusion? And I don't know if you have ever taken a look at this particular study.
Just to echo some words that we said earlier on. Remember, we said the physician anesthesiologists have been trained for, they're medical doctors, 5 years, then 4 years they went in for a master's in medicine in anesthesia. So they have a total exposure years of 9 years in training. So these kind of people have the knowledge, have the expertise, they have, you know, the intellectual capability of being able to offer that procedural sedation with the right mindset and with the right amount of drugs that they need, with the right equipment, standby equipment. In the contrary, we have now the other cadres that have come in who only undergo probably, I think it's less than 2 years of training. So it's a matter of expertise and a matter of exposure during our school days. It's a matter of exposure during the training period. So when you have such a study coming in and showing that there's a gap between these two cadres, the aim is not to look against the study. The aim is to how can we perfect it? How can we improve this? And that is where, as the Kenya Society of Anesthesiologists, we come in. We as a society, we identify the gaps that are being experienced by different cadres, by different hospitals, and we identify those gaps, and then we set up goals. What do we do? What are we looking at? What are the outcomes we want? How do you want these clinical officers trained? How do you want them to carry themselves out at their workplaces? So that is where the anesthesiologists come. We now offer a supervisory role to try and reduce these poor outcomes, or to try and reduce these inefficiencies that are being seen across the spectrum of the anesthesia care. Because we are few, we are 216. We cannot cover the whole country, but we can at least try and improve the quality that is being given by these other cadres. There's something called task shifting and task sharing. Okay. So with us anesthesia, because we are doing the same task, but we're not the ones who are doing it. So it's like we're shifting that task to the clinical officer so that they can be able to bridge the gap. Because in the UHC, what are the three things? We're looking for accessibility, we're looking for quality of care, and then we also have we want to reduce the financial impact, the catastrophic expenditure. So we have all that in mind when we're sorting out, or when you're trying to reduce and improve the outcomes.
Dr. Mbadi, will you say that this conclusion is painting a bad light to non-physicians? Well, as much as both of you really agree that it should be combined kind of work, but then is it the kind of training that is the problem here?
Let me start by saying, what is procedural sedation? What that means is being put to sleep a little, and most of the time it's outside the operating room. Maybe it's in radiology, or for example in cancer patients when they want to plan their treatment, or for children who are getting cancer treatment when they want to make sure you should not move, so the beam goes where it's supposed to go. Or maybe in the endoscopy suite where they want to put a scope down your throat. It's not full surgery, but just to remove the discomfort. And what I'm saying is it's normally sedation, which is anesthesia, in an environment that is not familiar. And the reason I'm saying that is because outcomes are multifactorial. You cannot pin it to one thing. It could be training, it could be poor resource availability. For example, you might find you had planned for a sedation, a procedural sedation in a particular maybe radiology suite, and then you go there, once patient has slept, there was no oxygen, there is no monitoring, there is no help, someone who knows what is happening. So I think part of that also beyond the training is also for facilities to equip their facilities with what is needed. KSA has produced national anesthesia guidelines that shows the minimum equipment that should be available before someone gives anesthesia. So I think part of that also is, it could be also the resource availability and even the support. And you find that most places where non-physician anesthesia providers work is remote areas most of the time. And I think those places should be supported. Like now, I'm sure because of advocacy, we want to bring more monitoring equipment to different facilities, because if you monitor someone, you know where they are. This oxygen, we want 100, is it 100, is it 70? But sometimes you're just giving and you don't know where you are. You need a roadmap to know where you are and to intervene, because sometimes you may know what to do, but you don't know where you are so that you know what to do. So I think it's support to different cadres, and also resource availability, and also debriefing, because we have a very litigious culture. People will not come and say what happened. Right. We need to be able to have that space for people to say what happened, so that we can all learn from it. We don't do the same mistake. Yes. Before
we get your last words, Dr. Kimani, for the 216 of you, are you always constant in one place, or do you go around the country? Maybe even training some of this, the non-phys, about the nurse, anesthetics and other anesthetic providers. Do you go around training them, probably, in different medical facilities?
So out of the 216, majority are, of course, would be Nairobi, but we have representatives who are probably employed or working in different counties. We have some in Nyeri, we have some in Nakuru County, we have some in Mombasa. So what happens when we identify an area that requires training, we could either mobilize the people who are locally situated in that county. If there's an anesthesiologist in that county, we'd mobilize them with the support of now a few others who are located from the society. And then now we create a curriculum, we create a program. When we identify what exactly needs to be trained, and then we offer the service depending on what is being trained.
Right. So this means, Dr. Mbadi, that there are areas that you look at and you say, well, this one, because I mean, you're saying 216 is quite low. You definitely need to increase this number. So when you're taking a look at even the whole regional, the whole country, the areas that the KSL looks and says where we'll really need a lot more of anesthesiologists in these particular areas. Which areas might this be, for example?
Before I say that, I wanted to say that health is devolved.
Okay.
And I know counties have been training their own, especially during COVID and after, when people realized the need for ICUs.
Yeah.
And people realized that they needed actually anesthesiologists. Before, maybe they thought they didn't, but now people are training their own. Counties are sending, because before it was national government that would send, you finish your training, you're posted somewhere. But now health is devolved, each county trains their own. If they need someone, they're able to train their own. And some have fewer than others. But I think...
Training locally, or do they go and send out of the country?
By training, I mean like medical officers who finished. They have worked in the county. They're interested in doing anesthesia. They can come back for training. And currently, physician anesthesiologists are trained in Nairobi, University of Nairobi, Moi University, Jomo Kenyatta University of Agriculture and Technology, Aga Khan University. So they can come back to any of those centers, do their 4-year training, and then go back to their county. If their county wants them to subspecialize, or even actually Kenya, our society also supports subspecialization training. Like, for example, if you want to go and specialize in probably the UK or India or wherever else, the World Federation Society of Anesthesiologists has stipends for that. And currently in Nairobi, as we speak in Kenya, there is a training for pediatric anesthesiologists for children. Because you notice there are so many children and there are very few pediatric anesthesiologists who are able to handle them. And on top of that now, we normally have a program called Safe Peds, which is safe anesthesia through education for pediatrics. We train clinical officer anesthetists from different regions so that at least children are safe.
Right.
Same to obstetrics also for mothers.
Right.
Yeah.
Right. Now for the parting shot, I'll start with Dr. Kimani. Your last words. I mean, we've definitely talked about quite a range of issues here. Onco, anesthesiologist, matters focusing on cancer, what the government should really be doing. But in a summary, in 2040, I mean, they're talking about a rising, cancer cases. What should we really be doing to tame this?
Just to add on, or to add on my conclusion is, with the new health bill, we have now a new cadre, the community health workers. I think it's the role of also the Anesthesia Society to train these community health workers on how to identify emergency cases, because they'll be the first doctors or the first providers to meet a patient in the community. So the role of the society now is we're adding a new focus whereby we want to try and see how can we equip these community health workers with basic knowledge or with basic skills of being able to manage patients who are not able to go to a facility as a primary facility. Because at the end of the day, we have to agree it has to be a continuum of care. The care that you offer at the beginning, the care you offer at the center, the care that you offer at the end should all be seamless and should all move in one tangent. So that is one of the things that we're looking at as a society that we're going to look at. And we just want to also appreciate all the anesthesiologists out there offering their care, offering their support, offering their clinical acumen to the patients out there, and even their clinical leadership. We thank you, all of you, and we continue praying that we shall work together to at least improve and offer efficiency in this country.
Most definitely. Dr. Mbadi, your parting shot.
I look forward to the day when cancer patients will be able to get timely diagnosis and comfortable treatment, meaning good pain control. And even if it goes to end-of-life issues, they face their end-of-life with dignity. That means pain-free, well taken care of, and that is a role that we have to play. So that onco-anesthesia, like people feel the effect of anesthesia in cancer care. I would also want to wish everyone a happy Anesthesia Day, and I hope our input has added something to their knowledge.
Oh yes, most definitely.
Yeah.
And I hope back home you've learned quite a lot. Asante sana, Dr. Ruth Mbadi and also Dr. Rachel Kimani, both of them are consultant anesthesiologists. Yes, not quite a mouthful one, anesthesiologist. We'll take a short break. When we come back, taking a look at what is happening in different parts of the country in our county diaries. Stick around for that.